Atrial natriuretic peptide comes from the Latin natrium, which means sodium, and uresis, which means excretion. So atrial natriuretic peptide stimulates the excretion of sodium, and, as I often say, as sodium goes, so goes water. So sodium and water loss. ANP is released from the right atrium of the heart, which is stretched under high venous return. So if venous pressure rises, signifying an increase in blood volume, the right atrium becomes stretched, and as it stretches, the stretch-activated ion channels, cation channels, allow sodium and calcium, especially calcium, to enter the cell and promote exocytosis of the vesicles containing ANP. In addition, the endothelial cells release endothelin-1 under conditions of cardiac ischemia. Endothelin-1 stimulates an endothelin receptor, and this is a G-protein coupled receptor. I'm only showing it as a big block. IP3 then stimulates calcium release from the endoplasmic reticulum. Endothelin-1 also feeds back and stimulates the endothelial cells to begin the production of nitric oxide, which then inhibits endothelin. So this is a negative feedback loop. ACH from the parasympathetic nerves stimulates the production of IP3. IP3 stimulates calcium, which then triggers nitric oxide synthase to produce nitric oxide. Nitric oxide inhibits endothelin and stimulates a soluble guanylate cyclase, which then produces cyclic GMP and inhibits the stretch channel. So there is an excitation and an inhibition. In a smooth muscle cell then, ANP stimulates a particulate guanylate cyclase, and that guanylate cyclase then is responsible for converting GTP to cyclic GMP. Cyclic GMP then is responsible for phosphorylating the protein kinase G, which stimulates phospholamban. Phospholamban promotes calcium uptake into the sarcoplasmic reticulum. This also causes a decrease in cytoplasmic calcium, which leads to muscle relaxation. Protein kinase G also stimulates the closure of calcium channels on the membrane, so less calcium in, more calcium being taken up by the SR, reduced calcium in the sarcoplasm itself. And it also promotes the opening of potassium channels, which hyperpolarizes the membrane, further inhibiting muscle contraction. I showed this figure in the renin-angiotensin discussion. Angiotensin II stimulates through a G protein, phospholipase, and diacylglycerol, which promotes the production of aldosterone. Atrial natriuretic peptide promotes cyclic GMP production, which then stimulates protein kinase G and inhibits the angiotensin II response. Angiotensin II and ANP are functional antagonists in this system. Now let's look at what happens if we have an increased effective circulating volume. Our blood volume is now rising. One of the things that does is to turn off renin. It also stimulates the right atrium by stretching it to release ANP. So ANP concentrations increase. ANP inhibits pituitary secretion of ADH. So ADH is going down. And if you remember from my discussion on ADH, ADH is the hormone responsible for recovering water. Well, we want to try to lose water, so we want to inhibit ADH. In addition, it inhibits sodium uptake in the cortical collecting duct. It inhibits the adrenal gland, and I showed you that just in the previous slide, to reduce aldosterone secretion. It inhibits renin to reduce the production of aldosterone and angiotensin II. So the goal here is to get rid of sodium and therefore get rid of water. So we want to turn off both sodium uptake, which is aldosterone, and water uptake, which is ADH, so that we can lose sodium and water. There's another peptide. We call that type B natriuretic peptide, but it's sometimes called brain natriuretic peptide. Brain natriuretic peptide was first discovered in porcine brains, and it was given the name brain. We have no idea whether it is found in human brains, but it is released when ventricular muscles are dilated. So during heart failure, extreme dilation of the ventricles will cause the release of BNP. And BNP and ANP are virtually the same. There's a disulfide bridge. These are the conserved in red amino acids, and everything else is variable. An increase in plasma volume then will cause an increase in right atrial pressure. That increase will cause an increase in atrial natriuretic peptide. Atrial natriuretic peptide is a potent vasodilator. Atrial natriuretic peptide also causes a reduction in sodium reabsorption and therefore an increase in sodium and water loss. Atrial natriuretic peptide and type B natriuretic peptide also cause a decrease in cardiac hypertrophy and a decrease in fibroblast activity. Heart failure, which leads to ventricular dilation, will cause an increase in plasma BNP, which will have the same effect as ANP, including sodium excretion. ANP and BNP may have paracrine or even autocrine effects. That is, the release of these hormones may have direct effects on the cardiac vasculature. So, in case of ischemia, ANP and BNP may help to mitigate the problems of ischemia. We use BNP as a marker for heart failure. A patient presents with dyspnea. We look at the BNP levels. If BNP is less than 100 picograms per milliliter, we would say that congestive heart failure is very unlikely, about a 2% risk. If BNP is greater than 400 picograms per milliliter, then we would say congestive heart failure is very likely, 95% probability of congestive heart failure with BNP levels this high. There's this gray area between 100 and 400, however, and what we want to do is look for other causes. For example, acute pulmonary embolism. These are instances of pulmonary hypertension. Pulmonary hypertension could lead to ventricular dilation. If we do find these conditions and any other condition that can cause pulmonary hypertension, we would say that CHF is unlikely, and that is about a 25% chance of heart failure. However, we cannot find other causes for the dilation and the BNP release. We would then conclude that CHF is likely, heart failure is likely, and we would put that at about a 75% chance. Once again, I'm going to show this target, which I've described in other discussions. An increase in atrial natriuretic peptide occurs under hypervolemia, volume expansion. Increase right atrial stretch causes an increase in atrial natriuretic peptide, causes a loss in sodium and water, bringing volume down. Hypovolemia, if you've seen the discussion on renin-angiotensin, causes sodium and water uptake, and therefore volume expansion, bringing volume back up here. And in the discussion I gave on ADH, hyperosmolarity will bring back free water, bringing us back to normal osmolarity. And under hypoosmolar conditions, decreasing ADH will cause osmolarity to rise, bringing us back to our target. And that ends this talk on ANP.